The next thing to talk about is amyotrophic lateral sclerosis. In short, ALS. In case you see Lou Gehrig's disease, and Lou Gehrig's disease is the same as amyotrophic lateral sclerosis we are talking about. Okay, so let us take note of it. Now, let's see what we have here. Then after, we can see what to add. Talking about ALS or amyotrophic lateral sclerosis, we are saying it is a debilitating neurodegenerative disease with no cure. I want you to pay attention to that. It's very important. Okay. So ALS do not have a cure. Let us take note of it. Sometimes, apart from Lou Gehrig's disease, you are likely to see this name, just in case. CH, forgive my pen, AR, it's like Charcot, right? Who has seen it before somewhere? Apostrophe S. So Charcot's disease. So either you see ALS, which is amyotrophic lateral sclerosis, or you see Lou Gehrig's disease. You're likely to see Lou Gehrig's, if not amyotrophic lateral sclerosis. But just in case you see this one, so it's the same thing we are talking about. Okay, Charcot's disease. So it's a progressive neurodegenerative disease. It's a progressive one that's continuous. And what it does is it affects your motor neurons in the brain. Motor neurons, when we you see we've bolded the motor neurons here. So we have sensory neurons and we have motor neurons. Right? Motor neurons are those that controls you. Okay. So that is with what we are saying here. All right. So it affects mostly the motor neurons in the brain and spinal cord, leading to muscle weakness, paralysis, and our main concern here, like other paralytic diseases or diseases that end up paralyzing you, is a respiratory concern, right? So that is what it is. No one knows the cause. So the cause is unknown. All right. The cause is unknown. So let us take note of it. And um, some of the things that you will see physical symptoms like fatigue, progressive muscle weakness, your muscles can twitch, muscle spasms, difficulty swallowing. So you see all these are motor activities, difficulty speaking, and respiratory failure, which is a main concern. So you see difficulty swallowing, which has something to do, especially at the junction, yeah, meeting. Okay, that's your oropharynx. It's our main concern because if you don't have full control over there, you can easily aspirate. And the main thing of all, respiratory failure. Okay, so that is what we have here. And how do we, before we even come to this last point, how do we diagnose this condition? We can do some nerve studies. MRI too can be done. Then genetic, it can have some genetic predisposition. So we do that too, okay, to find out whether um it's from genetic source. We can do that. Okay. Uh-huh. Have I mentioned MRI? For most neuro cases, MRI is very sensitive for most of them. Okay. And please, when it comes to the management, like we said, it has no cure. Okay. But there's you see what happens is that we have certain chemicals called glutamate or glutamic acid. What is produced in the or it is the weakens the nerve and let them die out. Okay, so we have if you have a drug which is counteracting the glutamate, you can say it is called anti-glutamic agent, right? You can call it that. So we have some anti-glutamic agents or glutamate inhibitor, anything that inhibits the production of glutamate, because that is what weakens the nerves. Okay, so when the nerve cell dies, it dies at all. It is not like how the liver cells are for them to replenish themselves. When a nerve cell dies, it dies. So what you can do is that we have a drug that can help protect the rest, or they can have you can have a drug which will preserve the remaining ones. It's similar to glaucoma. You see, when you have glaucoma, as soon as it's diagnosed, depending on how far your optic nerves have been degenerated, if you start your your drugs, your glaucoma drugs, what it does is it will not reverse your previous loss of vision. But what it's going to do is that it's going to preserve the remaining one. So when someone is taking drugs for glaucoma, and the person will be like fused, especially in our locality, some of our patients, sometimes if the education does not go well, it is their concern that whenever they use the medication, they should have everything becoming normal as it was before. So most of these nerve drugs, what they do is that they help preserve the remaining one intact. Okay, they leave them intact, but what has been destroyed has been destroyed. So coming back to my point, we have a drug that can help protect other nerves, okay, the remaining nerves. All right. Who can mention the name of the drug? A second.
Boss, please, I know of
Please come again. What did you say? Hello? Someone was saying something.
yeah, I was saying I know of carbamazepine for the neuropathic pain.
Mm, okay, so we have a drug called Riluzole. Okay, think that is. Oh, sorry. I think that is the generic name. Let me see if I can write it here. Riluzole, or if you pronounce it Riluzole, whichever. So this is a drug, Riluzole. So it helps to just preserve some of the nerves and give you um some time more. Okay. But we still arrive at this last point we have here. For about 20% or even more of people who get this have life expectancy of up to 5 years. Only about 10% or less than 10% can live up to 10 years. But generally, life expectancy is up to 5 years. You see how pitiful it is if you are diagnosed. All right. So that is this condition. If you have any question about all that we've talked about, amyotrophic lateral sclerosis, you can bring it out so that we help you. Any question? Sister Patricia, you can talk.
Hello, sir. Please, my line went off when you were talking about the diagnosis, how we diagnose it. I'll be grateful if you can come back. Thank you.
How the diagnosis is.
The thing I heard that's how you I heard you were asking how it is diagnosed. Then my line went off. When I came back, like you've already
Oh,
finished.
okay, I made mention of nerve studies, right? We have some nerve studies you can do, and I also mentioned MRI, and I did mention genetic testing to fish out the predisposition. Okay.
Okay,
So these
thank
are
you,
the
sir.
three things I mentioned about the diagnosis. And I also mentioned that you see, for most neuro cases, MRI can help. Not all though, but most neuro cases, MRI can help us diagnose it. So I think there's something that I want to add. Apart from this condition having no cure, like I mentioned, the Riluzole, right? Right, sorry, Riluzole. This medication, Riluzole, Riluzole. It only gives you some time to preserve some nerves, right? When things get worse, okay, let's say in cases of respiratory failure, like any other condition that arrests the respiratory system, they would definitely need ventilation, positive pressure ventilation. So you have to think through those areas too, right? So if at a point in time, the disease progresses and respiratory muscles are affected, we'll have to give positive pressure ventilation, either invasive or non-invasive. Invasive ones are like the use of the endotracheal tube, tracheostomy tubes, and the rest. The non-invasive CPAP, those are the common ones. Any other? And because of so I think I have something to add. Maybe it's coming. We will meet it at the last side of this after my questions. Okay, we have some supportive treatments we can give to them. You see, okay, you let me leave it. When we are done with the questions, I think it is in our last it's on our last slide. Okay. So if you have question at this point, we can bring it. If not, I can ask you my questions in peace. My first question here. A client is diagnosed with amyotrophic lateral sclerosis. Which client's problem would be most appropriate for this client? Who can try? If you want. Who wants to try? There we go. Let's go.
Okay, I'll go for fluid and electrolyte imbalance
And your
because
reason?
my reason is that we learned that the body or the system is controlled by electrolyte. So the moment there are issues with them, like if there are issues with electrolyte, a lot of problems may happen. So that's why I'm taking it. I don't know a good reason why, but I know I'm taking fluid and electrolyte.
Okay, interesting. But when you pick an answer like that, you should ask yourself, is it actually in relation to the diagnosis? Okay, you try to fight that part within your head. Okay, you fight that part
Okay,
within you and see, massage the answer and compare it with the diagnosis, see
okay,
if there's any way they link up.
okay.
All right. Okay. Thank you for your submission. Any other? Can we get any other answer? I'm not saying she's wrong. If anyone wants to
I also
affirm
feel
with a
that
different, I'll come again.
the disease syndrome. I don't know what
You
it
pick.
is though, but from the what you have said so far, you are saying it causes a progressive degeneration of motor nerves, which mean neurons, which means the person is unable to walk, do anything with the muscles. So I feel the disuse syndrome because the muscles are going to be. Oh, okay.
Oh, continue. We are enjoying. We are enjoying the explanation. So yes, okay. It is disuse syndrome. When you talk about disuse syndrome, when particular muscle is not being used effectively for some time, you get muscle atrophy. Okay, that muscle atrophies. So that is what normally happens to these people. Because of their weakness, you will see that part or the part which have been affected becoming wasted with time. So that is what we call the disuse syndrome. So if you don't see disuse syndrome somewhere, and you rather find something like muscle atrophy, okay, or wasting, anything in relation to what we are talking about, you should know that could be the answer. All right. I hope you all understand. The next one. The nurse is caring for the following clients on a medical unit. Which client should the nurse assist? So we have 4 patients here, prioritization. No one will get to the NCLEX room without getting any form of prioritization question. I normally say this a lot. Prioritization is something you can't do away with, as long as the NCLEX is concerned. Who wants to try? Abdurrahman, can you try? Abdurrahman, are you here? Okay, Annette, can you try?
Hello.
Yes.
I'm looking at the number 3.
Is it
The
difficult?
client is pneumonia. The client is pneumonia. Who has a cough and nasal flu?
We can't hear your voice well.
Please, I said I'm looking at the number 3. The
Number
client is
3.
pneumonia. Yes.
Okay, okay. Let us take another answer. Thank you for your submission. Last person. Mr. Agnes, can you
Go
try?
for 1.
Uh-huh. Nana,
I'll go for 1
1, the
because
client.
ALS who is refusing to turn every 2 hours. And then 2, abdominal pain comes with normal nausea and vomiting. And then clients with pneumonia, because they use the excessive muscles, definitely they will be finding it difficult in breathing, which will eventually also affect their pulse rate. And then client who is complaining about receiving any pain medicine. So I'll go for 1 for me.
Okay, so let us apply this. Thank you, okay, for your submission. Let us apply this and see. I want to remind you of something. I'm sure anyone who has completed task 1 on your dashboard. Mr. Mary, I'm coming in.
Okay.
Anyone here who has completed task 1 on your dashboards have gone through prioritization, right? So if you remember everything you met in prioritization, if you remember everything you met during your revision or during reviewing the prioritization notes and the videos, if you remember everything, try and apply. Remember some of the things we said. Remember some of the things we said in there and try. We are doing ALS, but treat this question as a general question. That is how I want you to think when you get questions. Okay. And use all your prioritization skills. Remember, I've said it before. You can't do away with prioritization. And see if you still choose the answer you are thinking of right now. So I'll take one last submission and we'll continue. Mr. Mary, your hand was up.
Okay, I'll go for number 3 because we are saying that in assessing a client, you have to look at airway before briefing, then circulation. So in all this, the option 1 to number 4, number 3, I'm thinking that number 3 takes priority because the SPO2 being 90% is very low. It's very low. So I will prioritize that one. I will see that one before I'll come in thinking of seeing the clients with they not being able, refusing to turn. It shouldn't be a major thing. It's not an emergency. Although that's the client's, it's necessary for the client to be turned every 2 hours, but I'm not thinking that it can supersede that of the number 3.
All right, thank you. Sister Vivian, your hand was up before. If not, Sister Agnes, you can talk.
Okay, so I would have chosen number 1 because, hello?
Yeah, we are all listening.
Okay, so when we are using the principle of prioritization, starting from using the organs, I would have gone for number 1 because of the brain. Because I was thinking that with ALS, we are thinking that we have motor neurons that are being affected, and it's going to affect, destroy more nerves. But with the pneumonia case, having a saturation level of 90 in a person having pneumonia, I would have think that is a normal thing for pneumonia.
Okay.
That's what I was thinking of. Yeah.
Okay. All right. So I understand why you chose 1 from your explanation, but the answer is 3. Now let me say this. Let me address you before. You have okay. What's the name? Is it Siami? Siame.
Yes.
Okay.
I think the option 3 on pneumonia would be the best to select because SPO2 pulse oximeter reading 90% is very, very low and is below the normal for somebody suffering from pneumonia.
Okay, thank you. Thank you
Yeah.
for your submission. All right. Mr. Mary, you can put your hand down, okay? I think it's an old hand, right? Okay.
A new hand. I was saying that, when you were presenting, you said the client, they will need a assisted respiration because either you do a intubation or something. So apart from the pneumonia was just brought there to confuse us about the case, but you have to look at the parameters before you select the answer. The pneumonia was just something to blindfold you to be thinking of only pneumonia. But any
Okay.
client who have a pressing problem should be given priority to any other client. Thank you.
Okay. We are welcome. So let me say this pertaining to what our sister said before, when she chose option 1. You made mention of 90% pulse oximeter reading in pneumonia is considered normal because of the condition at hand. So we have, though, when someone is having pneumonia, we have clinical signs that the person will show. There will be dyspnea. Okay, that's difficulty in breathing, right? And all of that. When they mention something like difficulty in breathing in pneumonia, depending on what you are comparing it with, it's normal with pneumonia. Okay. But what I'm trying to say, or the point I'm trying to make here, is that we have red lines that you don't cross. When someone has pneumonia and they tell you with dyspnea, that is okay. When they tell you with increasing, they bring this kind of adjective to describe how the dyspnea is, like increasing dyspnea, then that becomes your priority in this case. Okay, you have to look at it. With pneumonia, though, you have respiratory concern, you have some kind of difficulty in breathing, but we still want your saturation levels. You know, you can still have some pneumonia patients with even up to 900% or 99, but still pneumonia will be there. So you should consider that part too. So no matter what the infection is or how the infection has gotten to, we still want to keep saturation levels above 93. That is from between 94 to 100. Okay. Look at conditions like COPD. When you have any of the chronic obstructive pulmonary diseases, either chronic bronchitis or emphysema, if you have any of them, and you have SpO2 of 90, 89, they are all normal with COPD, because no matter what you do, you can't get 100%, 99%. For someone with COPD, you can never get. So when someone with COPD is having 90, 89, sometimes even up to 88, when it goes beyond, or sorry, when it goes below 88, that is from 87, 86, 85, you don't also say that because the person has COPD, so it's normal. You don't do that too. So every one of them have their normal, but they also have their red lines you don't have to cross. So take note of those areas, okay? COPD 1, you don't cross below 88. If they have between 88 to 90, it's okay with them. But for pneumonia is different from COPD. So you don't want to go below 93. Please, are you trying to get what I'm trying to say? Do you get what I'm trying to say right now? Or some of you are still confused about the points I'm trying to make? Are we here or we are not here?
We're here.
We are here, sir.
All right. So you understand what I just said. So the answer becomes, it takes time for you to get them as you practice and practice and practice. Okay. And there are like some of these, the strategies. When we were doing prioritization, I wanted us to do plenty of them so that at least we will, but at appropriate time we shall do them. Okay. So that, when you get lots of conditions, comparing them, when they stick forever, like I was telling you yesterday. So the answer here is 3. Option 3, pneumonia with pulse oximeter reading of 90%. This is of respiratory concern, and this is of integumentary concern. So comparing integumentary concern with respiratory concern, we choose respiratory concern. The turning, you see, the condition itself, it has no cure. So I think to touch on another part of what our sister said, that prioritizing the brain. So the thing is, yes, this has affected the motor neurons in the brain, but it has no cure. You can't do anything about it. But the point one is talking in relation to integumentary, like protecting the skin, because it's talking about staining, not the actual diagnosis. It's talking about staining every 2 hours. And why do you think we think every 2 hours? It's because of integumentary, I mean, to protect the skin from pressure ulcers and the rest. So you let that your concentration be on that one, not on the general diagnosis like ALS. Please, do you get it now? I didn't take note of the name. Our sister who
Yes.
chose one.
Yeah.
You understand it now, right? Okay. All right. So let us look at our next question. The client is process, which intervention should the nurse implement? So let me see if we can relate. Is yesterday I was telling you that if you learn a lot and you don't practice, you are doing nothing. So you see, we've gone through and we've said about 80–90% of all that we should know about ALS. But you see how the questions are framed, very different. This is a typical one. Who wants to try?
I think I'll go for 3.
Your reason?
Yes, since the patient is going to eventually have respiratory failure, I think there should be a directive which will give him the chance to live, at least to be placed on a ventilator or something. But okay, let's start with the placed on long-term care. That one, I don't think it will not do anything much. The sigmoid colostomy, he is going to lose all his muscles, possibly not be able to move any part of his body. Then the 4, I feel motorized wheelchair. The patient is more or less paralyzed and he cannot do anything. So motorized wheelchair. I think the 3, advanced directive.
Okay, thank you. Let's have a go.
Okay. I would have gone for the 4 because with ALS, as we discussed earlier, so as the disease progresses and we will still be having problem with the defect with the neurons. So it's like most of the parts, the person will not be able to mobilize. So that's what I was aiming at. So if that's the case, in helping this patient plan ahead, you have to consider more of promoting the person's independency. So if you want to promote independence, you don't want the person to be reliant on the care system and other people for everything. You have to plan of maybe number 4. That's the motorized wheelchair. It's a form of like the electrical wheelchairs so that will aid the person to at least mobilize independently around and also to do a lot of things for him or herself. That's what I was thinking.
I like your submission, Sister Agnes. Okay, Sister Abigail, before Michelle.
Yeah, I would think I'm thinking of number 1, discuss the need to be placed in a long-term care facility. With the reason being that these are patients who are having issues with the muscle, every part of her, and so we need assistance with activities of daily living. So if she's in a long-term care facility, she will be taken care of there. Thank you.
You're welcome. Okay, Sister Michelle.
Okay, Michelle,
Hey,
my sister.
Mr.
Mr. Yeah.
Sorry.
So I'll go for the 3 because I remember when you were projecting the slides, you did mention that with this disease, the prognosis is like 3 to 5 years and the person is gone. So I'll go for 3 because the person will need to prepare an advance directive. And the question says, as the disease progresses, so maybe it's getting to the like latter part of the continuum. So I feel an advance directive will be important at this time because the person is almost getting there. So that's why I'll go for 3.
All right. Thank you for your submission. Norabek.
Thank you. I also go for 3. With the reason that with discussion of the need to be placed in a long-term care facility, even when you are the long-term care, there will still need you to make certain decisions. And then as the disease progresses, I saw you talking about difficulty swallowing. And this thing is affecting the muscles. So to me, I am thinking that at a point in time, this patient might not even be able to communicate. So the advanced directive, making a living will go a long way to help these patients. The 2, I don't see any connection here. And then teach the client how to use the motorized wheelchair. With the motorized wheelchair, yes, it's an electronic device, but you still need the hand to operate. Sometimes, even when they lose all the limbs, some will even use their mouth and other parts of the body that is active to operate these machines. And this is a progressive disease affecting the muscles. So it will get to a time they will not even be able to use any of these muscles. So I think I'll settle on 3. Thank you.
You're welcome. You're welcome. I think everybody has spoken, right?
Can I say some?
Okay, say some. Okay.
Okay. So I'll start from 4. I will choose 1 though, but I'll start from 4. It says teach the client how to use motorized wheelchair. You should understand that when the person is diagnosed, he has a 3 to 5 years of survival, right? And then one of the signs and symptoms, because it's affecting the spinal cord and then the brain, so it will get to a point their thinking and behavior will change. Their thinking and behavior will change. So using a motorized wheelchair in the long run is going to affect their thinking. A person who has a loss of consciousness or thinking impairment cannot use the motorized wheelchair. It's contraindicated there. And then looking at the 3, said assist the client to prepare an advance directive. In every setting or in the hospital, they always have a power of attorney, or they have a name for it for every client. Definitely, advance directive is important, but in the event that the condition deteriorates, the power of attorney or whoever stands in for a client might take decisions for him or her. And then looking at the 2, it has no connection. But because it affects the muscles and then the brain and the spinal cord, the client will need a long-term facility to be able to manage the client to its survival period of time in the event of any issues. Yeah, thank you. So 1.
Okay, thank you. So I think that'll be the last submission. Yeah, thank you very much. So the answer is 3. Okay. I've taken lots of things from all that you said, and I think I want to add 1 or 2 things to the ALS. Amyotrophic lateral sclerosis. Please, we bolded and we highlighted the motor aspects. Okay. Note that mostly about 80 to 90% of the time, it's only the motor neurons which are involved. It's only among some few, some of their sensory parts also becoming involved, like dementia. Most of the time, their mind is very, very intact. Though there will be weakness, paralysis, and everything, but they are mentally intact. That is one thing I want to let you know. They have a mental, intact state. So don't be deceived. It's only about motor. It's only few, very, very scanty people, about 10% or less, that will normally sometimes get some form of dementia because of what is happening. And there's another thing. Should you get maybe select that apply or in case study, please, there are no, because it doesn't affect sensory nerves. It doesn't affect bowel, bladder, and sensory nerves too. Generally, bowel and bladder. So though there's weakness, but it won't affect the bowel movement. So take note of it. It won't affect their bladder, as to control their sphincter muscles, whether to hold urine or not. Okay. So take note of those two things. So please remember, we said they have life expectancy of up to 5 years. The question says, as the disease progresses. So there was one sister who was trying to give us some explanation. Please, I took something from explanation too. One thing that we should note is that when you are picking an answer, try to relate to what is happening here. Okay, those of you who are taking long-term care for these patients, this condition will not even, how long do they have to even live? Look at the life expectancy between 3 to 5 years. So why the need for planning long-term care for these patients? You get a thing. And those who were saying you use motorized wheelchair, motorized, you still operate. And the motor nerves are all gone. So how will you operate this machine? For this one, there are some people with the advanced directive, there are some people they'll be like, when I am incapacitated, I don't want to be ventilated. I don't want to be resuscitated. I don't want this. They are all forms of advanced directives. So the patient can arrange for it. So that if the patient, has a DNR order, it's all part of the advanced directive. Whether DNR order, do not intubate me when my respiratory muscles fail. They can write some specific advanced directives. Some people do not want to go through that stress. They are like, if the time comes, let me go. Do not intubate me and put me on ventilator. Okay. And all of that. So the right answer here, in relation to what the question asks with ALS and the progression of it, option 3 is the best answer. Do you understand what we are trying to say? So when we pick the answer, let us relate to what the question is asking. That is how we can be best at answering our questions. Okay. Look at this question too. The client is in the terminal stage of ALS. Which intervention should the nurse implement? So look at it. Terminal stage of ALS. Which intervention? Questions on ALS are difficult. They're very simple too. But to require critical thinking. Very simple questions. You see, like this one, but you have to think. Who has the answer? It's Agnes, your hand is up. Do you want to talk?
I would have gone for 4. Uh, 4, to turn the client and have him cough and deep breath every shift.
Terminal stage. Okay.
Terminal stage.
I'll go for
It should
one.
tell you a lot of things. So you see, they've said it like very simple. You have terminal stage of ALS. Can they cough? You ask
No,
yourself, can they even cough?
you can't do anything.
So you see the question you should ask yourself. Who says she'll go for one?
I'll go for
I
3.
did.
Okay.
3.
Someone is going for 3.
The one, I feel the one, because you have to still improve circulation at least. So the passive range of motion every 2 hours at least to help the remaining whatever to
Okay.
be oxygenated. That's what I'm.
Okay. Thank you. I heard someone say 3. So this person with muscle atrophy, you will give low proteins, right? Is that what you are saying? Someone said 3.
No, sorry. It's 2 then. It's 2. 2, sorry. 2.
Maintain a negative nitrogen. Are you sure? Do you know
I
that
mean,
nitrogen?
looking at the options available, I think it is the odd one out for me. So,
All right, thank you.
mm.
Thank you, Lord. Nancy, Mr. Nancy, be the last person and let's go.
Boys, I'll go for 2. Looking at somebody in the terminal age of the ALS.
Oh, continue. Mr. Nancy, continue. It is 1. Maintain a negative nitrogen balance. Even if you don't understand this one, for me, though, let's say I don't understand this point too, but negative nitrogen balance, it's like you are reducing nitrogen in the patient. For me, I want to link nitrogen to proteins. You know, proteins contain nitrogenous compounds, right? So it is like lowering proteins. That is how I understand. I don't know if someone has a nice explanation to this point, but sometimes you can link answers and get some, I mean, when you are in the tight corner and get some understanding, that can help you answer some of these questions.
In fact, I didn't know the 2. I just chose the 1 because it just made sense.
2, 3, 4, 1. Yes. Okay.
So my question is about the previous question. I actually was thinking of number 1, and the reason was quite different from what you projected, but I just wanted you to hear to let me know if I was making sense. So for me, I was thinking that since the client is in the terminal stage, I would still want to make the client comfortable. So any, like intervention I can put in to make him or her comfortable, I'll do that. And so that was the reason why I was thinking of number 1. So I don't know if I was,
Comfortability.
yes.
All right. Thank you. Thank you.
Does that make sense though?
It makes sense.
Okay.
Consider
Thank
you lying at a place for longer time.
Mm-hmm.
I mean,
Yeah. Okay. Thank you.
so comfortability is
Mm-hmm.
also in there. Okay.
Right.
Yeah.
Okay.
You're
Thank you.
welcome. You're welcome. All right. So, like I was saying before, Mr. Gloria, your hand is up. You want to ask a question?
No, please, I just want to read the what do you call again the explanation for the question you just did. I just want the explanation again. Thank you.
But you heard everything we said,
Yeah.
right? Okay.
Getting these questions wrong, I think it's just practice that would help. Okay.
You had it wrong, eh? Hmm.
Yeah, it's kind of something.
All is well, okay? All is well. You'll be fine. So let us
Hello, I
practice
want to
make
come
it
in
perfect.
small. I don't know.
For which one?
Yeah, the current question. You see, I think one of the keyword in the question was that you highlighted was that's the terminal stage. And I was thinking at that moment, at that terminal stage of a disease, do we actually need to perform range of motion exercise for 2 hours? I think at that moment, you'll be more concerned about promoting comfort for the patient. And at that stage that you are expecting that the patient can pass away
Wait,
anytime
you
soon.
said for 2 hours. Every 2 hours or for 2 hours?
Every 2 hours is I don't think for terminal stage at
I
every
heard you
two
say for
hours
two
we
hours,
yeah, I
not
saw
for
in the
two
question.
hours. Okay.
Every 2 hours.
And I want to say
So
that I want to
what you're
say
trying to
that
say is 4 is wrong. Okay.
Yeah. So 4 is wrong, but the range of exercise
Someone
was
came
but
in.
for the 2 hours, every 2 hours.
Okay, you let me land.
That,
Okay, if you want to talk, you raise up your hand. I think someone
Can I
came
say
in late.
something?
I was
Let me
saying
finish.
that
Let me finish.
they
Let someone
didn't
come in.
say end of life. They said terminal. There are people with terminal illness who are still strong. They are able. It's end of life that you can say the patient is maybe in bed. You wouldn't want to disturb the patient and all that. I'm just chipping into the lady that just spoke.
So your issue is the word terminal, right? What do you know of terminal? Mhm.
An illness that actually doesn't have cure. It's like end stage of a disease condition. The prognosis are quite poor. So you'll be doing symptomatic
You said end
management.
stage, right?
Yeah. But it's not end of life. The patient has not been put on, and it is end of life cases that you wouldn't want to disturb the patient with anything. You maintain like absolute peace, free from pain and all that. So a patient with end stage condition, we can easily do a range of motion for the person. Doesn't mean the patient is dying today. I'm
So
just bringing it
are you
because of
saying
what
it
she was saying.
in support of the answer, or I want to get where you want to
The
land
range of
or how
motion
you
is
want to
okay. Me, I don't know the answer,
um
but the range of motion is okay for me.
okay.
Hello. Can I also say something? So based on the other lady's understanding, then the rest should be wrong, because if you are saying that you don't want to disturb the person, it means you don't want the person to get up and do deep breathing and coughing, right? And you don't also want to
You
start
see,
giving the person a lot of
let
food
me
and all that. So
let me come in right now. Let me come in right now. It's like we are even worrying ourselves plenty. Okay. And this thing will even sway you away from the question. The question is very simple. Even if not at the terminal stage and the condition is just ALS, 4 is actually wrong. Because when this condition is there, they cannot cough and deep breathe. But fine, let us consider the terminal age, the terminal stage of the condition. Look at the life expectancy. When we say terminal age of a disease, don't also think of a disease that has maybe a very long, life expectancy. We are talking about ALS to be more precise. So if you have about 3 to 5 years to live and you are at the terminal stage, how long do you have? So consider all of this when you are answering. 4 can never happen in the terminal stage of ALS. So it's actually wrong. there is already muscle atrophy, you have to give your normal or even increased protein intake. So 3 is also wrong. Okay. And I was relating nitrogen to also to proteins. Okay. How I explained. So if 3 is wrong in this person, then 2 might be wrong. This part is like you are doing something like hospice. Okay. It looks like a kind of hospice care. You don't treat anything. You focus more on comfort. That is why when our sister was it Genevieve? Genevieve brought comfort in, and I said yes, it's part of it. So it's all about comfort. It's like hospice here in this case. Okay, so how we are pulling the leg and the neck. You see, sometimes you end up even changing the question before you. So if it is wrong, it is wrong. You don't even bring it in to even consider. Okay, so 4, 3, 2, you throw it away outrightly. If it's wrong, it's wrong. You don't have to even massage it in order to try and see if you can consider. I don't know if you understand what I'm trying to say. So I think this is okay, right? So, if the person needs, so I've talked about this part up to medication. If the person need assistive devices, we can help, okay? With either walkers, wheelchairs, and the rest. And there would be constipation due to decreased mobility, okay? So this one is not because of sensory issues, but it's because of, you see, when you don't perform lots of exercise, you tend to have constipation. We have constipation that's because of sensory issues. As in this condition, who can tell us? There's a condition in which your nerves will lose all the your intestines will lose all the nervous activities in there. Paralytic ileus. Okay. As in like cases of paralytic ileus. You see that those ones are more sensory. Okay. But this is because of inactivity. So I think that will end ALS. We spent enough time on that. Let us look at aphasia. Now, sorry, when we talk about aphasia, what comes into your mind? Generally, aphasia. What comes into your mind? We have 2 types, okay? We have 2 types. So when we talk about aphasia, it's any condition that affects the way you talk, okay? Your ability to express yourself or communicate with one another, or difficult in speech. That is aphasia. Over here, you are saying brokers. We have 2 types, the brokers and Wernicke's. We look at that, but let us go by what we have on the slide and see what we can adapt. Explain them in the next slide. Is a non-fluent aphasia resulting from damage to the frontal lobe. I'll explain, okay? Clients with Broca's aphasia can comprehend speech, but demonstrate speech difficulties. It means they can comprehend, they understand. That's the meaning of comprehend, okay? Whatever you tell them, they will understand, but they can't talk. Okay, they'll have issues with talking or speaking fluently. So that's with expressive aphasia or Broca's aphasia. The speech pattern often consists of short, limited phrases that make sense, but display great effort and frequent omission of smaller words. Example like and is there. So they are okay with comprehension. Whatever thing you tell them, they understand. But when they are expressing themselves, they find it very difficult. Clients with Broca's aphasia are aware of their deficits. They are aware of, what's wrong with them, okay? And they can easily become frustrated. So when you have a patient with Broca's aphasia or expressive aphasia, you have to get time for them, have a lot of patience for them when they are, you are interacting with them, okay? So I think I've seen questions on that before. Just give them time for them to express themselves. In comparison, clients with Wernicke, that is receptive aphasia, are unaware of the speech impairment. So let me use this one to explain it better. So we have two topics here, or two headings. Okay, so these are just the topics, something like this. Okay. So under the syndromes, we have the first one, Broca and Wernicke. Then another topic is spontaneous speech. You see, for Broca's aphasia, or I think we can use this one to even take note of it, the expressive. So their names here depict what they lack. Okay, or it depicts their issue. So they can't express themselves well. But whatever thing you tell them, they understand. So if you look at under this topic, spontaneous speech, it's sparse and non-fluent, okay? But their comprehension is relatively preserved. You can reason with them. Whatever thing you tell them, they understand. And, this is located in the frontal lobe, okay, of the brain. That's the Broca's area. Then, with the Wernicke's area, or the Wernicke's receptive, their receptive is like you are receiving. They have issues with receiving information. They can't comprehend it. So that's why it has this name, receptive aphasia. When it comes to speech, they can talk plenty and very fluently, but one characteristic of what they say, or whatever thing they say, most of them lack voluminous, but they lack meaning or sense. So they can express themselves, but when it comes to the reception, okay, receiving of information and understanding them is greatly diminished. So you can't reason with them. So I'm asking, can we now differentiate between Broca's and Wernicke's aphasia? Are we clear now?
Yes, please.
All right, thank you.
Yeah.
All right, let us look at another thing here. Though we don't have questions on that one yet. Let's look at another condition. Coop country Coop injury. Okay. So I don't know if you've seen questions on this before, but these are, we have Coop injury and we have country Coop injury. We are talking about the two in all. So, okay, let us look at what is here first, then I will use it to explain. So this is an injury that occurs when the body in motion stops suddenly. So let us use this as an example. Let's say you are in the car and the car suddenly stops. Okay, you check when that happens, you check for it. So when, for instance, you hit your head, okay, on a car wind, let's say at a car windshield, or if you are the back seat, maybe you hit your head on, or let's say against a seat before you, anything at all, what happens is that, let's say you hit your forehead on a seat, or let's say on a windshield, okay, against a windshield before you. That point of contact, I mean your forehead in this case, hitting that point, whether the windshield or the seat before you, that will lead to the coup injury. Okay, so that one, coup injuries are like direct, they are directly to the point of impact. So if your forehead, the car suddenly stops and your forehead hits against a windshield or maybe a front seat, okay, for you, that head-on impact is called a coup. But something normally happens. In severe cases, your brain shakes within your cranium. Your brain is going to shake a bit. So when you get that coup, that's your front hit, your brain, as it does that, the brain moves forward, and the brain, depending on the tendency of the motion, or the potential energy of the stoppage or of the car, when it is stopped at once, when maybe it was in motion before, the brain will go back and hit the posterior part of the cranium or of the skull. Okay, so it's like, I don't know whether I have a picture here. So yes, there's a picture here. Let me use this to demonstrate something. Let's say this is your cranium, housing your brain. Oh, sorry. This is your cranium housing your brain. So let's say you have a windshield here. When the car suddenly stops, you hit your forehead against the windshield. This point of impact will be the coup. Okay, that's what I'm trying to say. And the brain will shake within the cranium. So as the brain moves forward, it will come back to, and this part is likely to hit the posterior part of your skull or your cranium. It's the cranium which houses the brain itself. So this is what we are talking about. And this part is what? Country coup. So this is coup, then this is country coup. So that's what I want to show or demonstrate to you with all that I
Show
was
the
saying.
country
Okay.
coup again. The country coup again.
Do you understand the instance I made with the car
Yes.
thing? Do you understand?
Yeah.
So I'm saying when your forehead hits, where you have the impact directly against that windshield, that is where you have the coup, but your brain will shake. So it will move forward, then the brain will move backward again within your skull as it shakes. And the occipital part is likely to hit your the back or the
So your line is off, it's breaking.
And that is what we call the country coup.
So your line went
No.
in some way.
Can you hear me now?
A little.
The rest of you, please, can you hear me? I'm still breaking.
You are breaking. You are breaking. So the previous thing he said, we couldn't hear you.
Yes.
Is it better now?
Yes. Yes.
Yes.
It's better.
Okay, thank you. So let me take the explanation again. With the so I'm saying, let's say you have, this your anterior part, okay? Let's say this your eyes. Yeah. So something like this. Okay, your brain is inside. Okay. So what happens is when you hit, let's say, your forehead or your head against anything before you, the point of impact is what we call the coup. Okay. You can have this part of the brain becoming injured, the frontal part. But because the brain is in the skull, that shake can, or that impact can shake the brain. That impact can shake the brain within the cranium or the skull. So as it hits the frontal part of the skull, it can also come back, okay, as the brain shakes, to hit the posterior part of the cranium or the skull. And this part is called the country coup, when you have the brain shifting back to hit the posterior occiput. That is the country coup. So that's what I was trying to say. Please, do you understand?
Yes,
Is it better?
yes. Thank you so
Yes,
much.
please.
Yeah. Welcome. So when this happens, okay, you are saying as the body bounces back, the brain strikes the opposing side of the skull. So that's country. So I've explained these points and this point too. So when the forward collision occurred, the frontal lobe most likely suffered the primary impact. Okay, the frontal part, like I said, which is the coup, it will suffer the primary or the initial impact. And you have issues with the frontal lobe. Some of the issues the frontal lobe controls or functions the frontal lobe of the brain controls is they are all executive functions. Okay, memory, speech. The Broca's area is located within the frontal lobe, the left side of the frontal lobe. So that's what we spoke about before this slide. So you can have speech being affected. And voluntary movements are also controlled by frontal lobe. Okay, so right now, when you want to think about raising up your hand, your frontal lobe of the brain also plays a role in that. All voluntary movements. With the country coup, it's most likely to affect, it is the occipital lobe which is involved. So, your occipital lobe controls vision. For this one, even if you are not a nurse, I think it is very common for even our mothers to realize that when someone knocks you at your occiput, you are likely to have vision issues. So whenever you have an issue with occipital lobe, your vision is likely to be affected. So that is with the country coup injuries affecting vision. So when you get questions and they tell you, if it's both, like coup, country coup, you can have these last 2 points, all of them happening, okay? Either this or this. But if they tell you or they specify that it's a country coup injury, do not pick any of these. Pick only vision. If it is only coup injury, it doesn't affect vision. It affects only the memory, speech, and the rest, voluntary movements, actions, or functions. All right. Any question?
Please, can you say the last bit again?
Which part? What I just said.
Yes.
So I said when you get injuries involving when they tell you it's country coup, we understand country coup now, right? And if they give you a list of options, country coup injuries affect only the vision. If they mix it up with all of these things up here, it's not part of country coup. If they make mention of only coup injuries, it affects only the frontal lobe of the brain. So that is with this point, all the points here. But when they tell you coup, country coup, all of them, then you can mix all of them. Is it better now?
Yes.
Okay.
So, sir, how different is this one from concussion?
Concussion, who can try? Coup, country coup, you have the whole brain moving, okay? But concussion, you can have the brain also shaking though, but I don't know if someone can try. Before I'm trying to compare the concussion is a traumatic brain injury, right? Of which this country coup too is coup country coup is how do we call it? It's also traumatic. They are all because of trauma. So what I can say about this is that with concussion, it just describes the whole injury. Okay, that is what I can say. It describes the whole injury. Let's say if you have any trauma coming against the head, whether hitting your head against anything, that is concussion. But coup, country coup, they are used to describe specific injuries. That is what I can say. Because coup injuries will affect only the frontal lobe of the brain. Country coup will affect the parietal lobe. Okay, but when you mention the term concussion as a whole, it is the injury itself. The head hitting against something. And that is non-specific. And when your head hits against the hard surface, you can have other issues also happen. So in short, what I can say is that coup country coup is more specific. Okay, concussion is general. That's what I can say. It's Agnes'
Okay.
hands up.
Thank you.
So let's account first.
Okay, what I wanted to say was concussion is a temporal injury to the brain. So it occurs within a shortest possible time. And the patient might exhibit that sign of confusion. And it's just a mild process. It doesn't take long for concussion with that. So it's like in case maybe a person is engaged in a road traffic accident and we say the person is having concussion, that means there is a temporal changes within the brain. That means in case he hit it temporarily within some few hours, the person will be confused. So it just occurs like that. But as compared to what we are studying right now, so I think concussion, if somebody is having a brain injury right now after an accident, the concussion you will see it as a first sign that will come. So I think later on when it progresses, that's when you will be able to determine whether it is the coup or the other one that we are talking about.
Which
That's
other
what I
one?
think.
Okay, I understand. You don't want to mention the name.
Yeah, it's too
Okay,
long.
yes. Yeah, so I think that is it. Concussion is like a general term. Concussion can lead to coup country coup. Sometimes concussions as our sister said, after getting your confusion, like temporarily, you can regain your consciousness and nothing will happen. But you can also have other parts of the brain being affected, which could not necessarily mean coup country coup. But there's one thing you can be sure, that concussion, depending on the impact, can also shake the brain, like we are saying. So concussions can also lead to coup. So it's like Cook Country Group is more specific to the kind of injury that has occurred in the brain. Okay, it's more specific. I don't know if all the explanations we've given you understand.
Yes, it's better.
Uh-huh. Please, any other question? Or addition? Okay. If not, then let's talk about Bell's palsy. I want us to cover a lot today before we close. Okay, Brother Francis.
Yes, sir. Please, I would like to know the difference between concussion and contusion. Are they the same, or is there any difference between them?
For concussion, you know right now, right?
Yes, sir. Yes, sir. I know it now.
So who can help us with contusion? Contusion leads to pool of blood. You know contusion that you get some bruise or
Yes, please. In
no,
contusion, you have
and I
in
think
contusion you have
I think contusion is not specific to only the brain. Do you know we have lung contusion? We have lung contusion and other contusions. You can get contusions even on your hand. So contusions are like it's not more specific to the brain. Okay, it's like
okay.
having bruises somewhere. So you can have lung contusion. You can have it's like a bruise if you have a bruise somewhere. That's how I understand it.
Contusion.
But concussion, when you
for
say concussion, concussion is mainly the brain.
Okay. Okay. That's what I want to know. Thank you.
You're welcome. Or any other person with a better explanation. I think this is okay, right?
Yeah, I think that's it. Contusion is more to wound ties. I mean, wound description kind of. Whereas concussion is with the brain problems.
Okay. So in short, maybe contusion means bruise, of which bruise can happen anywhere. And concussion is mostly with the brain. Please, I hope I can still be heard. My voice is not gone, right? Can you hear me?
Yes.
Okay, so let's talk about Bell's palsy. Okay. When we talk about Bell's palsy, over here we are saying, some will say palsy, right? Some people here, I will not mention names, they will say palsy, Bell's palsy, right? So Bell's palsy, which is the same as peripheral facial paralysis, is an inflammation of the facial nerve. Please, cranial nerves. Oh, yesterday someone asked, I put the GCS on the page. I wasn't reminded, so it escaped me. Please, after someone should remind me, okay? I'll have to also drop the cranial nerves and what they do, okay? Also in there so that at least we can do some references. Cranial nerves, when you know them, is better. It helps you solve lots of issues and you understand things better when it comes to neurology. You know, talking about facial nerve 7, if like facial nerve wasn't here, how would you even know you're talking about facial nerve? Okay, so there are 12 cranial nerves. Let us try and learn them. Okay. So talking about Bell's palsy, it's an inflammation of the facial nerve, that's cranial nerve 7, in the absence of other disease. Okay, etiologies like stroke. You can have stroke also affecting, stroke can give you symptoms of this. So you have to elicit stroke and be sure that what is happening is not stroke. It's rather Bell's palsy. So this affects mainly the cranial nerve 7. Sometimes it can affect the cranial nerve 5 too. You know cranial nerve 5, who can tell us? Cranial nerve 5 is what?
Trigeminal.
Trigeminal nerve. Good. Trigeminal nerve. So sometimes it can also affect it, but it's mostly affect the facial nerve. Okay. So there is flaccidity of the affected side with drooling. You see the tendency, like you see that part of or that side of the face like drooping. Okay. I mean, the elasticity of that part affected will be very, very poor. I mean, it will be like it will be sagging. Part of the face will be sagging or something like that. But the patient will lose control on that part. So this differs from the concerning drooling with epiglottis or epiglottitis. Okay, in which the client's throat is too sore and swollen to swallow saliva. So this is because a nerve has been affected. How do we treat Bell's palsy? But before that, I'm coming. Let me see if I have the picture here. We have other things to talk about Bell's palsy. So I think the picture is here. We can see. So you see the peripheral facial paralysis or palsy. So this is affecting more of the left side. Okay. So we are going to use this one. Let us just gaze on this one and add up some other things. Most of the times, these conditions are like autoimmune diseases. You know that. And for most autoimmune diseases, there are some viruses or other conditions which normally spikes them. Okay. It's normally, I mean, what English word should I use here? It normally awakens them for them to be prominent, okay, or for them to come up. So most of things that normally awakens autoimmune diseases. Per what I've seen for now, I don't know if someone has also recognized that. Viral diseases. Talking about virus and herpes simplex virus. Okay, these some of the okay.
Please, you are breaking.
For most
So we didn't even hear what you said, though.
let
Your
us
line
mute
was not
up.
stable.
Cassandra, mute up, okay. So I was breaking again, eh?
Yes.
Sorry. Okay. Sorry, so you can hear me now. So what I was trying to say is that with Bell's palsy, and it is an autoimmune disease, right? And like most autoimmune diseases, you have it's normally virus, okay? Viruses that normally awakens it. Most autoimmune diseases, people are born with them. They have the predisposition, but they will never come out until infections, especially from viral sources. And the most common ones I have seen is the herpes simplex virus and I think Epstein-Barr too. So mostly it's virus, okay. But for with this Bell's palsy, you have viruses like herpes simplex virus, especially the type 1. We have two forms of herpes simplex, right? We have type 1 and type 2. How do you differentiate type 1 herpes simplex from type 2? How do you differentiate? Type 1 is the one that involves cold sores, right? It affects the mouth. you have these cold sores and blisters around the mouth. Okay. And it's normally contracted from kissing an infected person and doing some other things, right? Like oral sex and some other things, you understand, right? With the herpes simplex type 2, that one is more of a genital one. So that one is contracted when you have unprotected sex with an infected person. That is the type 2. But for this one, you're talking about the type 1. The type 1 normally precipitates the condition. I mean, this condition we're talking about. You can have herpes zoster 2 also precipitating it. So let us take note. It's an autoimmune disease, and it's normally precipitated by this viral disease I'm talking about. Okay. And as you can see on the screen, you have unilateral facial paralysis or weakness, which means one side. So look at something. If your one side of your face is paralyzed, do you think you can control frequent blinking here in the eye? Do you think you can control?
No.
Oh,
So they normally tends to get dry eye syndrome. Okay. So in order to prevent that, we normally use tears, or we cover um, with eyelids. Okay. We either cover or we lubricate it. Okay. We lubricate with artificial tears, or we give eye patches. That is what I mean. Eye patches in the night to prevent the ulcerations and dry eyes. Okay, because of, when your eyes, you don't blink and your eyes are just on like this, they will dry and you will get ulcerations, corneal ulcerations and the rest. So you cover at night with eye patches, right? Then within the day or at frequent times, you can be giving the artificial tears so that it helps lubricate the eye. All right. Then what else can we talk about? This condition that we haven't done. And generally, they have decreased lacrimation at the affected side. Okay. Tears, I mean, you have scanty tears in that eye. So that eye is definitely not lubricated well. What else can we say? Apart from the weakness. So if you are managing them, if you are managing them, I don't know if someone wants to okay, let me ask this question. It's a nice question. Who can differentiate Bell's palsy from stroke? Who can differentiate that?
Hello, sir.
Yes.
So Bell's palsy, from what I'm learning, will affect just the facial muscles. It will affect unilaterally to one side of the face, but stroke will affect one side of the body. So it will include the face of the part affected, the hand and the leg.
And the leg. Okay, so fine. Yes, so that is true. But okay, so I think my question wasn't framed well. I want to concentrate on the face alone. What you said is perfectly true, but there's something different from stroke.
Hi.
Face, yes.
I
hello.
think the patient with stroke also have swallowing difficulties, but this one with the Bell's palsy, they have the facial muscles, especially the forehead, the chin, and the jaw paralyzed. Compared to the patient who have one-sided paralytic and paralyzed, and then with the swallowing difficulties as well.
Okay. I also think the stroke is different from this because for this, the paralysis causes inability to blink, but stroke patients are able to blink. They're able to use the part a bit than what you're explaining for these people. This one looks like
Okay.
it's gone off. entirely.
Okay.
I
Please
also
drop.
think the course will
Raise
let you
up your
know.
hand before you talk. Raise up your hand before you talk, please. Otherwise, you have plenty of people talking at the same time. Okay. All right. So I think what you said is true. Okay, Sister Mary.
I'm thinking that the stroke and the course will be the one that will help you to know whether it's stroke or it's a Bell's palsy.
Are you saying
Because
cough?
somebody cause of the paralysis, cause of the paralysis.
Okay. Okay.
The cause of the
All right.
paralysis can let you know whether
Okay.
it's Bell's palsy. Because
Okay.
I
Thank
know
you.
somebody who had the facial muscle weakness due to accidents. So
Thank you. I think
depends on the
you're
cause.
even relating it far. All of you. Like I mean most of you are relating it far. It's like when you see the face right now. One thing about this is, by Richmond, your hand is up. You want to add a voice. Okay. Uh-huh.
What they are saying, see that the person still have the with the belly passes, the eye is dry because they have scanty tears. So with the stroke, their eye still work. Thank you.
Okay. Okay. Thank you very much. So I think most of us we've said it in different ways. You've done well. So with those parts, see, everything is paralyzed. Even with blinking, they can't blink. Okay. And they can't close their eyes on that part. And there's one particular thing. It is with their eyebrow or the ability to close the eye. Do you know that in stroke patients they can close their eye? In stroke, they can close their eye and they can raise their eyebrow in stroke despite the paralysis. But in Bell's palsy, they can't. Okay. In Bell's palsy, the entire half of the face, including the forehead and the eyebrow, cannot be raised and they cannot close their eyes. But with stroke, the forehead is spared, the forehead. So they can cause some wrinkles. Okay, they can raise their eyebrow and all of that. So that is what I wanted to add up. You've done well.
And then say, I'm just imagining the thing. Stroke patients will not have the face drooling like Bell's palsy, except when they talk. So until they talk, it is when they speak, they start to talk. That is when the face or the mouth shifts to one side, the affected side. But
Okay.
with Bell's palsy, you can just looking at the person, you can actually see the parts affected.
The paralysis.
Yes, you can see the face drooping, like dropping or drooping, whichever way you want to say it. It's so
Okay.
obvious with Bell's palsy. Else is a
Okay.
bit considered in.
Okay. Thank you very much. Thank you very much. So how do we diagnose this condition? By clinically observing the patient. Okay. So you can look at the unilateral facial weakness and also help diagnose. You can also do MRI. Remember, I told you with most new cases, MRI can help you look at it. Then, what else? I think those are the two common ones I can say right now. When it comes to the management, most of autoimmune diseases, steroids are encouraged. Okay, steroids are encouraged, and especially when it is earlier to can you give this drug, or how do we call them? Immunoglobulins. Can you give immunoglobulins? I'm asking. Please, can you hear me?
Yes, we can hear you.
Hey, You're not answering me. Can you give him immunoglobulins?
For the Bell's palsy,
Yes.
I'm not sure. Does it revive the nurse?
Okay, so in which condition? I think it's not actually needed. Okay, in this one, we have one condition where you have to definitely treat with immunoglobulins and aspirin. This is just by the way. What's the name of the condition?
Kawasaki.
Good. Let's carry on. Okay. So with the management, with Bell's palsy management or Bell's palsy management, you need steroids, right? Like prednisolone and the rest. And if the cause is from a viral source, you will have to treat the cause with antiviral medications. You know, the commonest ones we can talk about is acyclovir and the VERS. Okay, the other VERS, antivirals. Then, these are the medications, some of the medications you can give, right? We are talking about Bell's palsy, right? Okay. Something came into my mind, but I'll mention it somewhere. Can we also give eye protection, like we said before, to help
Yeah.
protect? Yeah, you have two people
I
saying,
can't see your screen. No. Yeah, it's still showing the picture for me. I don't know if that's what you're
yes,
showing.
all that I'm saying, I'm just saying it too.
Oh, okay.
Yes.
Thank you.
You see, I think let me see. The next one here is my question, say. So I'm just adding
Okay.
up. Okay, that's why I want us to look at the picture so that I
Thank you.
add up some more. Okay. All right. And most of the time, say, when you have this Bell's palsy or palsy, normally they are temporal, they resolve on their own. Okay. But some patients might have this for up to some time. Okay. Sometimes within 3, 4, 5, maximum up to 6 months, you have it resolved. But some few people will take it up to some time. All right. I think that is all what I can
Did you say
add
how
right now.
long?
Any question from anyone?
Boss,
You
please.
said how long?
Get that point.
Please come
Your
again.
line is breaking, so I
My
didn't
line was
really get the
breaking,
last point.
You
but can you
said
hear me
how
now?
long? How
Oh, I
long does
said
it take?
up
Yes, you
to,
can
let's
hear
say
me
from
now.
3 to 6 months, sometimes you can have it up to 3 to 6 months and it will go off. But some people can take it, more than that. But mostly it resolves within this period, 3 to 6 months. Only few people will carry on with
It's how did you say it is managed?
the management. We talked about drugs, that's prednisolone, which is
Okay.
like,
Prednisolone.
corticosteroid, right?
Steroids. Okay.
Yes. And
Okay.
we said that if the cause is from maybe a viral source,
Acyclovir. Yeah, I heard that one.
like you can give that one too. Then eye protection, to help protect the
Sure.
eye. So when you get endless questions on these ones, they normally concentrate on, you see, when you are feeding these patients, you have to put the food on the stronger side of the patient, right? Not the weaker side. So they talk about this airway protection thing, the eye protection thing, and sometimes the medications you will give. These are, and you have to do some form of exercise to physical therapy. Okay. These are the areas they normally cover for questions that I have seen on Bell's palsy or palsy. Okay. So to round everything up, the medications, the eye protection, the feeding aspects where you will have to put food at the stronger side, facial exercise. Okay. So those are the safety concerns. Anyone with any addition or question to ask?
Sir, how would you differentiate I came across this disease, Joshua disease with Bell palsy.
Which disease?
just is it SJO Josquin? SJOGRENS.
Ah, how do you pronounce this word? I think the S the S or the J is silence. I think it's Sjogren's syndrome. That's how we pronounce it. Sjogren rather. Okay,
You
it's Sjogren's. So Sjogren's disease is also a neurological disease, but well, it's autoimmune disease too. Sister Sandra, you want to say something about that, eh?
No,
Okay.
no, I wanted to say that they said this Bell's palsy, so they have some extent of loss of taste.
Loss of teeth.
Taste, like
Taste.
tasting food. Yes.
Oh, okay. I've not seen that one yet.
Okay.
Okay, wow. Thank you for that addition. Okay.
Thank you.
All right. So back to our brother's question. This Agnes, you want to help her?
Yeah, I've actually nursed a patient with that condition before,
Sjogren's disease.
surgery. Yeah. So
How
that
do you pronounce it?
condition, she told me it says surgeon.
Sjogren.
I think
Okay.
the J is
It's silent.
absent. Yeah.
Yeah.
Yeah, it's silent. So that condition, actually, it affects body fluids. So with that, mostly their eyes are extremely dry and saliva, everything. So that condition is mostly related to dryness. It's about fluids. So it doesn't have anything with the nerves. I don't know if you understand what I'm saying. So with that condition, if a patient is having, you see that their eyes is extremely dry. So with eye drops, you'll be applying different kinds of them. I met a patient with that and she actually explained everything to me. So you will see that even with saliva, mostly they are on artificial salivas and other things. So that's the key thing about that condition. It doesn't have an effect on facial nerves and other things.
Good. Thank you for
Thank
bringing
you.
that up. So one affects what we talked about, facial, Bell's palsy or palsy affects the nerves. Then this one affects exocrine glands, right? Exocrine gland that helps in the salivary production. I mean, salivary gland is one of them. Then your lacrimal glands, the one that controls your tears and eye lubrication. And I think it's general, so it's systematic. Or should I say systemic rather? It's systemic. Sjogren's disease is systemic. So it affects all secretions generally in the whole body. And it doesn't affect, it's autoimmune disease though, but it doesn't affect any nerve. I think that's the difference. Thank you, Sister Agnes. Sister Sandra, you want to say something? Brother Francis, your hand to yourself.
It's not
Please,
this
you guys should spell it.
Yeah.
Oh, okay. SG. Let me write it here. Sorry. SJOG. I think it's this, right? Sjogren, then maybe apostrophe is disease. So the J is pronounced silently. Are we okay? All right. Any other question or addition? Let us pick, spare me your time small. Let us do some few additional ones, okay? So that we can go. I know time is up. Let's pick these questions quickly. When teaching patients who are at risk for Bell's palsy because of previous herpes simplex infection, see, like I was talking about, which information should the nurse include? Let's pick them quickly. Yes. Just one person.
Hello, sir.
Yes.
Yes, please. I would go for B.
Treatment of herpes with antiviral agents will prevent development.
Prevent development of Bell's palsy.
Okay. Okay, Sister Mary.
I
Add
will
yours.
also go for B because we said herpes simplex virus infection can lead to a Bell's palsy.
Okay.
Hey.
Oh, you're saying the you're saying the look at the question. You should call the doctor if pain or herpes lesions occur near the ear. So, treatment of herpes with antiviral agents will prevent development of palsy. Are you sure? Look at this one. So it means when you have okay, so wait. Let us look at the question and understand it. When teaching, I'm coming. When teaching patients who are at risk for Bell's palsy because of previous herpes simplex infection. So, is someone talking? Patients who are at risk for Bell's palsy because of previous herpes simplex infection. Which information should the nurse include? You should call the doctor if pain or herpes lesions occur near the ear. Treatment of herpes with antiviral agents will prevent development of Bell's palsy. So remember, though antiviral medications can help treat this one, but that is not the only cause. Okay. Medications to treat Bell's palsy or palsy work only if started before paralysis. No. Let's see what the rationale has to say. Pain or herpes, when I was mentioning the causative agent, I also mentioned varicella zoster, right? Varicella. Though herpes is herpes zoster, but you still have varicella, the same causative organism in there. So we are saying pain or herpes lesions near the ear may indicate the onset. Okay, so I think this is a new thing we can add up to notes, okay? Pain or herpes lesions near the ear may indicate the onset of Bell's palsy, and rapid steroid treatment may reduce the duration of Bell's palsy symptoms. Antiviral therapy for herpes simplex does not reduce the risk. For that one, yes. We said it can precipitate it, but it doesn't mean that it will prevent you from getting it. That one is not there. Then steroid therapy will also be most effective in reducing symptoms if it starts before paralysis. Okay. Let's have your hand is up.
Brahima, please, can you go back to the question? I just want to take a screenshot of it.
You want to read more on it?
Yes.
So look at the question. So what makes...
All right, thank you.
All right. So I think we all agree, right? Let us look at it for the next one. I want us to please spare me your time small, okay? Oh. Come on. Okay, so this is the next question. A patient with Bell's palsy refuses to eat while others are present because of embarrassment about drooling. The best response by the nurse to the patient's behavior is to do what? The best response by the nurse to the patient's behavior. So your preamble is there. Okay, we have some hands up here. It's Agnes. It's Abigail. What's your... Is it an old hand or a new hand? It's Agnes, you can talk.
Sorry,
I would have gone for A. respect the patient desire and arrange for privacy at meal times, because all the
Okay.
other options are not respecting her wishes.
Yes. Yes. So I think that is it. It's A. Okay. It's Agnes, you want to talk? Or you just spoke? So the answer is A. Okay. All right. Can we talk about this quickly before we go? Or we should take it as an assignment?
Fair.
Okay, so let me rush through it so that we can go. Okay. Trigeminal neuralgia. Take, how do you pronounce this word? Deliro, right? Take Deliro. So either you say that one or trigeminal neuralgia is the same. So this condition causes chronic pain, okay, which affects your trigeminal nerve. Your trigeminal nerve is it's part of
Right.
the facial, like it's on your face, okay. Trigeminal, it controls your facial muscles too. Cranial nerve 5. So what you normally see or you normally see about these patients is that they normally tend to have chronic pain. So just take it as that they have chronic pain on their face. Okay, it's as if someone is stabbing their face. And the pain is very sudden. Okay, and it's mostly triggered by what you see here, touch. When they talk, hot or cold air or intake. So when they take two hot foods or two cold foods, it can stimulate the trigeminal nerve. The pain is very excruciating. All right. One drug that helps to tame these patients. I mean, first class, we have levels of medications you will have to give, or lines. First line medication you will have to give is carbamazepine, okay, or those pain medications. Please mind you, if you don't see carbamazepine on your exam or elsewhere, you see something like anything that ends in zipine, okay, carbamazepine, those zipines, like oxcarbazepine. We have a drug like that, oxcarbazepine and the rest, they are all the same thing, right? So that's the first line treatment. You can also, it's a form of neuropathic pain. That is pain directly from nerves. The nerves themselves are causing the pain. So you use drugs that can help with nerve pain, not just acetaminophen and these NSAIDs. So the second line you can go is gabapentin. We've all heard of gabapentin before. G-A-B-A, that's GABA, then P-E-N-T-I-N, gabapentin. You can use that drug. Then I think there's another drug too, baclofen, B-A-C-L-O-F-E-N, baclofen. So first of all, you can use either the zipines. Okay, carbamazepine is fine. Second line, baclofen or gabapentin. All right. So let's take note of that. What else can we add? We've described the pain, right? What else can we add? Sometimes this thing, it can come and go. Okay, but please take note of the triggers, because these are the areas where questions might appear. Okay, anything. So just imagine a nerve in the face causing that. When you touch it, when the patient chew, when they talk, even sometimes cold wind, okay, or taking in anything cold or too hot. And sometimes when you want to even shave them, yes, it's also part. When maybe you get a question and it looks like they have bushy beard or something and you want to shave, be careful. Okay. So I think that is it. You know how you diagnose them, the presenting signs and symptoms, like how we did for the Bell's palsy. Okay. Presenting signs and symptoms is one. Then, if possible, you can take MRI too. So also check it out. Right. All right. So I think that is all. It's very simple with this one. That is all what I have to say. Let's pick these questions quickly and see if we can maybe end it here. When assessing a patient with newly diagnosed trigeminal neuralgia, the nurse would ask the patient about, this one is easier. Which one should we choose?
A.
Yes, I think it's easier. This one, we shouldn't even waste time. Yes, that is A. Mr. Mary, you wanted to say A, right?
It's the same.
Okay, so let's look at the next question. During assessment of the patient with recurrence of symptoms of trigeminal neuralgia, the nurse should do what? Reoccurrence, okay, or recurrence of symptoms of trigeminal neuralgia. The nurse should
D.
D for dog.
C.
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 Some are saying A, some are saying C.
C.
C. C.
Okay.
C.
Okay.
C. C.
You see?
Can we see the question again?
You see, we said touching the face is contraindicated.
So how do you examine the mouth and teeth? You want
Look
to
at
touch
wait. Maybe you didn't understand the question. During assessment of the patient with reoccurrence of symptoms. So the thing is, are we supposed to examine the mouth and the teeth? Is that what the question says? Okay. So this is just a free range question. And we are asking, what should we do? We are saying just touch. So you see, this is a trick. It's good. It's good this question is here. Examine the mouth and teeth thoroughly. So you can have them open their mouth and you check. But wait, when you are examining the mouth or teeth, do you have to put your hand in someone's mouth or shake someone's teeth?
Yeah, no.
You see the thing? So one thing is, even if you're not sure about A, B, C, D are entirely wrong. If you want to use the elimination method, look at B. Have the patient clench and relax. Clench, the clenching alone will make the pain worse. So this is an off word that they shouldn't do. Let me pick my pen. This clench thing makes this whole sentence wrong. Trigeminal neuralgia, how excruciating and piercing the pain is. They can't do this, so it makes B wrong. Identify trigger zones by lightly touching. So this is just a word just to deceive you. But do not touch their face, please. Do not touch the faces of people who have trigeminal. Otherwise, someone will slap you. Do not touch their face. This one, you see this one to palpate. They've intentionally added gently. Please, there's nothing like gentle palpation in trigeminal neuralgia. Just don't touch their face. Yeah, Sister Delade.
Sorry, I'm just wondering, this person that has pain on the face, when you have pain on your face and you're opening your mouth and I'm examining thoroughly, won't I be rather triggering exciting the pain more? I'm just wondering.
When you examine, so you see, that is why they didn't give you a strong point here as your answer. Because when, you see, I recently talked to someone who wrote, the person, like, I laughed plenty. The person had a certain experience. It's like, the person told you that even when you know maybe some options are wrong, even when you are choosing the one that you know it's correct, sometimes you are even confused whether it's actually the right, because they won't make it so clear to you. They will never make it so clear. So look at this. You don't know much about how it's going to be done. But these words I have highlighted in options B, C, D is a no-go area in trigeminal neuralgia. Please, no matter the case, do not touch their face. So it's a no-go area. So you see, look at option B, option C, option D. It made the whole thing wrong. But look at this. Examine if only you can only choose or throw this away if only you think that when you examine someone's mouth and teeth, you'll have to put your hand or touch the teeth or put your hand in their mouth or something. You let them sit down, you stand in front of them, they open their mouth, okay, gently. Then you can inspect with a pen, light pen, and all of that. You can inspect. Even if someone does not have this condition, trigeminal neuralgia, and you are examining the mouth and teeth, do you have to put your gloved hand inside their mouth or something? It's Vivian. You have ENT people here.
Hello.
Yes, Vivian.
Okay, so my question is, if we examine the mouth and teeth, it's just like we are just observing the mouth, and then what exactly will be in the mouth that will tell us that this person is having
Good.
a trigeminal?
Good. Good. So let me answer that. Wait, let me answer that. I understand you. So that is one thing about NCLEX. Do what you are. I mean, they've asked you to do. Do not think what you think is right. Okay. When you get that's how the NCLEX is. I wish we have. I don't know whether we have someone who has experience here. The thing is, you see, if they give you a positive answer, that's direct straight to the treatment. Okay, direct straightly to the treatment. You will fish it out and point it out as the correct answer, and you go your way. Okay, so we've given you options, and you're supposed to choose between the options. So you choose one that has allowance, not one that you think is going to treat the patient, but one, even if it's a point that will not harm the patient, but will not do the patient any much good. But it's a generous, please follow what I'm trying to say. If let's say you pick an answer, when you are comparing your answers, and you have answers that are absolutely wrong or contraindicated, you throw them away completely, because what is wrong is wrong. And let's say if you are left out with one option, that is not actually bad and not contraindicated in the patient, but even will not do anything positive for the patient, but will rather, I mean, it's like a normal something that you can do, but will not treat the condition. It could be the answer to that question, if only the rest of the options are absolutely contraindicated. So you will not always get an answer that will target your exact treatment. Please, do you understand the point I'm trying to make?
Yes.
It's Agnes, you understand first.
So, I think I will add up to what you are saying. Now that I understand why it is A. So looking at the question, they say that the reoccurrence of symptoms of the trigeminal neuralgia, and when we were describing the condition, they said that I think the most common symptom there is the pain. That is severe facial pain. So if there is reoccurrence, that means we examining the mouth and teeth thoroughly is to also rule out if there are other factors that are also contributing to the pain that the patient is experiencing, looking at the reoccurrence of symptoms. Because when we have any condition affecting the teeth, either it is teeth decay or any other thing, maybe it will also add up to the symptom why the patient is having that severe one. So, and looking at all the other options that you're saying, yes, we are not supposed to touch, we're not supposed to palpate, not supposed to clench. So I think A will add up for them to analyze the condition well and give the appropriate treatment.
Exactly what you're trying to say. Thank you for the addition. Noravik.
Yes, following your explanation right now, I picked up something and I wanted to share. So we just finished treating the condition, and then we know that we are not supposed to have anything to do with the face. And going through questions, what I would say is we move from the known to the unknown. So you know that you are not supposed to have anything whatsoever to do with the face. And the right answer is the right answer because of the other answers.
Yes.
So going through it, just avoid anything that has to do with the face, because one, touching the face is prohibited. So anything that has to do with the face, you know it is wrong. So just cancel all those out. And then whatever is left, whether you are sure or you don't know, for the three you are sure you are not supposed to do. And that leaves us with A. So I think if we have that mindset, we will clear some of these confusions. Thank you.
All right, you're welcome. You're welcome. So I
Yeah.
think we have the rationale
So,
here to have something we can go through. Someone wants to talk without the hands.
I wanted to say that the other lady
Okay.
made so much sense. She
Okay.
made so much sense in the fact that we are dealing with a recurrent pain. So if it's a recurrent pain, you may want to assess if there are other factors, other things in the mouth, and things concerning the mouth and the teeth, they greatly affect the face. They bring radiating pain to the face. So to assess for the reason for the recurrency, you really need to rule out other conditions in them. I think she makes so much sense to me.
All right. Thank you very much. I think we have another one here. When the nurse is planning care for a hospitalized patient who is experiencing an acute episode of trigeminal neuralgia, an appropriate action to include this. So you see this one. This is very similar to the previous question. Let's see what you choose. Very similar.
I'll choose B.
I'll choose B.
You're all seeing B, eh? So you use the same approach.
B.
Have you seen it? Yes. So that is it. Because of our time, I wanted us to touch on multiple sclerosis. Please read on multiple sclerosis. Then Guillain-Barré syndrome, maybe another time. So you read about these two conditions, multiple sclerosis and Guillain-Barré syndrome. At appropriate time, we shall meet and go through them. Okay. It's very important. Try and